During labor and delivery, there is going to be some obstetric emergencies that is very important to be aware of during the NCLEX questions when they ask you. So let's take a look at them. These are must know obstetric complications that can occur during pregnancy and when if you're having labor. Which obstetric complications should the nurse suspect? You have to know these kind of complications: uterine rupture, placenta abruption, cord prolapse, amniotic fluid embolism. Which of these information indicate the instructions given or the case given? A laboring client experiencing spontaneous rupture of their memory. That's the buzzword. Spontaneous rupture of the memory should give you a clue about what condition will happen. Immediately afterward, the fetal heart rate dropped to what? 80 beats per minute. How do you answer this question? It's a test-taking strategy and content mastering, right? The nurse should suspect this, right? Complication, right? Rupture of the memory is key with guiding this complication. And the kid heart rate drop. These are buzzwords. When you see them, when you hear them, it should give you a clue. These are buzzwords. Rupture of your memory, all of a sudden, heart rate drop to what? 80 beats per minute. And then they're asking you what complication will be responsible for that. What do you think? Is a lady is in labor, all of a sudden, rupture of the memory, then you have what? Bradycardia of the baby, fetal heart rate drop to 80. That's deceleration. What do you think? Content related question. Which one of these is associated with the rupture of the memory? A uterine rupture, placenta abruption, cord prolapse, and amniotic embolism. If you know the answer, you can type it. The key concept here is here, spontaneous rupture of memory. When you rupture your memory, what is going to happen is you're going to lose your amniotic fluid. As soon as you lose amniotic fluid, the cord prolapses with it. And therefore, that leads to what? Deceleration. And this is why the kid heart rate is dropping. So every time a patient is undergoing labor and they rupture their memory, the next thing the nurse is supposed to do is to look for what? Cord prolapse, not uterine rupture. Uterine rupture will lead to what? Sudden cessation of contraction. Placenta abruption, you're going to have dark blood coming up from the vagina with the painful contraction. Amniotic fluid embolism, they're going to have airway issue. This is how you master content. You look at each answer choice. You don't care whether it's a bad problem. So far as it does not answer the question, you are not going to pick it. The right answer is when you lose your memory, rupture your memory, and you lose amniotic fluid, there is a risk for what? Cord prolapse. This is the same thing. If you just answer it, you get trapped. Which actions are appropriate during encleptic seizures? That means the lady is having seizures, right? Select or apply. A nurse is caring for a client with what? Preeclampsia. You know, patient has preeclampsia. There is a risk of developing eclampsia. And therefore, the question is asking you active seizure. That's all. Patient has preeclampsia and you're taking care of the patient. All of a sudden, patient is now in eclamptic seizure. This is different. Pre-eclampsia, you're watching it, and now she's having seizures. You can change the question and say, what do you do when a patient is having seizures? Do you pad all the side rails? This is how you answer questions. You see, I changed the question. The way it was framed is confusing, designed to trap you, not confusing, but designed to test your test-taking strategy. Patient had pre-eclampsia. Now she's having eclampsia seizures. What actions do you take? Pad the side rails, turn the client on their side, place oxygen by max, administer calcium gluconate, or suction the client. What do you think? If you know the answer, put it down. Somebody is having seizures. Which of these should you do? Is a test-taking strategy designed to trap you? Which of these should you do? Of course, we're going to pad the side rails. We're going to turn the patient on the left side so that they don't aspirate. You cannot put oxygen on a patient who is having seizures. It's a trap, right? So this is wrong. Calcium gluconate is designed for what? Magnesium toxicity. You don't give it to a patient who is having seizures. And you don't sanction the client who is having seizures anyway. So you see, 1 and 2 are your right answer. It's designed to trap you, to let you think that knee-jerk reaction you don't pick. But these are obstetric emergencies I want you to master so that next time when you see them, you can get rid of it and answer the question quickly. Which of the following causes should the nurse suspect? This is the same thing. This is the same thing. But if you don't take care, you miss it. So which of the following should the nurse suspect as the cause? A nurse is assessing a laboring client with what? Tachysystole. Which of these do you think can cause tachysystole? So the buzzword is what? Tachysystole. Causes of it is a select or apply. You see, I'm connecting my buzzword. Tachysystole, causes of tachysystole, and I have select or apply. Then you go with your content. What is tachysystole? That means the contraction is more than what is expected. You're contracting at least more than 5 in 10 minutes. Therefore, if this is what is happening, which of these do you think can cause tachysystole? What do you think? If you know the answer, you can put it. But which of these information can cause tachysystole? Is it fetal distress, Pitocin infusion, urine rupture, prolonged labor, magnesium sulfate overdose? Think about the question carefully and think about what is happening. A nurse is assessing a laboring client for what? Tachysystole. Which of the following causes should the nurse suspect? What do you think? If you overselect, you lose more points. But think about it. Fetal distress is not the cause of the tachysystole, right? Fetal distress will lead after the tachysystole, it causes is a complication of tachysystole. So there's a difference. Complication of tachysystole will lead to fetal distress. So don't pick it. Pitocin infusion can lead to tachysystole. Too much pitocin will cause excessive contraction. Uterine rupture will not lead to tachysystole. When the uterus rupture, there is a cessation of contraction. So everything stops. I'm trying to let you master the content with this question, put it together. So there's a cessation, there's stop of contraction. You're not going to have tachysystole. When you have prolonged labor, you get fatigue, no contraction. And when you have magnesium sulfate overdose, same thing. It can contract. So these are the things you have to know you can figure out that, oh, this is it. A person in prolonged labor will not have tachysystole because the uterus will contract for a long time and it get tired, right? It's not going to go into tachysystole. So there's only one answer. It's Pitocin infusion. That is the purpose of this question. Okay. A nurse on Pitocin is having, a client is on Pitocin is having 6 contraction in 10 minutes. That is tachysystole. What is the nurse priority for this? Do you give them tubulin, which is going to slow it down? Do you notify the provider who is going to give you orders? Do you stop the Pitocin or perform vaginal exams? This is straightforward. You give the patient something, it's contracting too much, stop the poison. Tubulin will block the Pitocin, it will slow things down. But so far as the Pitocin is going, it became ineffective. If you have Pitocin going and you try to give them tubulin to slow them down, it's not going to help. The best thing is to stop the Pitocin. Calling the doctor It will tell you you have the choice to stop the Pitocin. So you don't need to call me. Vaginal exams is not going to help you in this situation. So stop the Pitocin. A client with preeclampsia developed tonic-clonic seizure. These are obstetric emergencies you have to know. Tonic-clonic seizure. What is the next first action? It does not matter whether they are in preeclampsia or not. It means patient is in seizures. These are the things when they ask you questions, you go through. This is what we call risk reduction a potential, right? It basically attack every area. It's a maternity, but it has fundamentals in it. So you see pre-eclampsia, you think, oh, this maternity question. Then all of a sudden, I said tonic chronic seizure. Oh, this is seizures. That means answer the question related to seizure. And this is risk reduction. That is why it's a little bit difficult. All the question is asking you, when a patient is in seizure, do you check for cervical dilation? Yeah, she's in pregnancy. She is, I mean, she's having labor. She has preeclampsia. What checking cervical dilation is not going to help you. Patient is having seizures. Giving them magnesium. Magnesium does not prevent seizures in the patient who is having seizures. Magnesium is given to a patient in preeclampsia to prevent seizures. But so far as they having seizures now, we have to give them something that will deal with the acute problem, like benzodiazepine. But magnesium is not going to do that. We lost the battle here. Restraining the client is going to make things worse. And therefore, the best thing we can do is to turn the patient on the side to prevent aspiration. This was designed to trap you because a lot of people will pick magnesium because they know they see preeclampsia, but the question is not asking you about preeclampsia, it's asking about patient's tonic-clonic seizure. Same thing. What should the nurse anticipate assisting with? That means, what do you think the nurse will be anticipating for? What is she going to do? What is she going to assist with? A nurse notes the fetal head retract immediately after delivery. Think. The information there is all you need. A nurse notes that if the fetal head retract immediately after delivery, what should the nurse anticipate assisting with? What will she think? Okay, the head goes back. What am I going to do? The idea of this question is for you to master content. What does that mean? The fetal head retract immediately after delivery. What is your diagnosis? In the case form, you will see this. What is your diagnosis? This is what? Why would the head retract? We call it total sign. And what does the total sign means? Total sign happen when you have what? Shoulder dystocia, right? The baby head go back and forth, back and forth. And so this is a obstetric emergency. Instead of me telling you patient has shoulder dystocia, I use the description of what is going to happen. The head comes out and then go back like a turtle sign. And therefore, how do you manage it? You can change this question instead. What do you do when you see shoulder dystocia? That's all. The same thing has been asked. These are some of the questions you see to say, oh, I can't answer it. You know it. It's just changed in a certain way. Instead of me saying shoulder dystocia, I said no. The head retract immediately after delivery. That means what? This is shoulder dystocia. What do you do? Do you do fundal pressure? Do you use vacuum extraction? Do you do Mark Robert maneuver or Leopold maneuver? What do you think in a management of a patient with shoulder dystocia? I can tell you, number one is a trap. Fundal pressure is always wrong when you see shoulder dystocia. It's a wrong answer. When you apply fundal pressure, you're going to kill the baby. Vacuum extraction is going to make it worse. And Leopold position is changing position of the baby, but not in shoulder dystocia. So the right thing you do is Mark Robert, where you apply suprapubic pressure, counter pressure with the mommy leg flexed towards the abdomen. That is Mark Robert maneuver. You have to know these problems, shoulder, dystocia, and do you manage it? It's a Mark Robert maneuver, and this is the same thing, head retracting backward. So 3 is the right answer. Okay, so watch for that. Next question is, a client at 30 weeks gestation present with painless vaginal bleeding. What do you think will cause painless vaginal bleeding? What will cause painless vaginal bleeding? What is going to cause painless vaginal bleeding? That's the bars rate. Perform vaginal exams, place client in the lithotomy position, prepare for ultrasound, or encourage ambulation. What do you think? The bars rate is painless vaginal bleeding. Painless vaginal bleeding is what? Placenta, what? Previa. What do you do with placenta previa? That's all. What do you do with placenta previa? Do you perform vaginal exams? Do you place the client in a lithotomy position? Do you prepare for ultrasound? Or do you let the mommy walk while they're bleeding? I know this is painless vaginal bleeding. I suspect placenta previa. But what is the key? I have no clue. I need to confirm it. Every OB patient bleeding, no vaginal exams. The lithotomy position is not going to help with this situation. Get an ultrasound. It will tell you this, the placenta is laying at the cervical os. And that would tell you that, confirm the diagnosis of that placenta previa. And so this is what you do. Mommy walking, somebody who's bleeding is not supposed to walk. We can't let her walk anymore. Okay, so if she was bleeding, she shouldn't be walking. That is the key. Okay. A postpartum client suddenly becomes cyanotic and collapses. She just had a baby. All of a sudden, this is what happened. Which of the following the nurse should prioritize? Buzzword, cyanotic, and collapse. Think about it. These are obstetric emergency. What condition will cause you all of a sudden have a baby and boom, you collapse? One, either you have PE or you have amniotic fluid cause of the PE. That's all. There's nothing. Giving mommy Pitocin is not going to help her. Checking for cervical dilation for somebody who has collapsed is not going to help them. Placing them, the client in a high Fowler position, the patient has collapsed and is cyanotic. It's not going to help. You should call a code. The next one is number 9. A laboring client suddenly reports tearing abdominal pain and the fetal heart rate drop to 80. Which of the following the nurse should prioritize? A tearing abdominal pain. The sign is tearing. That's the buzzword. There is so many emergencies, right? There's a uterine rupture, there's placenta previa, there's a placenta abruption, there's shoulder dystocia, amniotic fluid. I'm giving you clue. I intentionally said all those things. These are the buzzwords you should hear and know what signs and symptoms associated with that. Placenta previa, you know that what? Painless vaginal bleeding, placenta abruption, right? Dark vaginal bleeding. This one we have tearing abdominal pain and the fetal heart rate is dropping. This is what? Rupture, uterine rupture. The uterus rupture, what do you think? Mommy is no more pushing because there's going to be cessation of contraction. There's no need to monitor internal bleed, fetal monitoring. Foley catheter is not going to help you. We got to go and deliver the baby. Mommy is in shock and she's going to die if you don't do anything about it. These are all content related. And the last one, a laboring client experienced spontaneous rupture. This is the first question. I changed it. I'm trying to show you that you cannot memorize question, but they can change it. They can flip around, but the content remain the same. A laboring client experienced spontaneous rupture of the memory. Immediately after that, the fetal heart rate dropped to 80 beats per minute. What should the nurse do first? Place the client on their side, give them Pitocin, check for cord prolapse, or give IV fluid. This is the same thing. Whenever there's a rupture of memory, you lose amniotic fluid, it flushes the placenta out, and there's a risk of what? Cord prolapse. Of course, we got to place the mommy, change position. First, lift the and presenting cord, change position. But even if you look at the answer choice A, changing position on the left side is not going to help. It's usually knee to chest position. We don't give Pitocin anymore. We'll give you IV fluid. We'll check for cord prolapse. But the first thing we got to figure out if mommy is as a cord prolapse.